Neurology, pathology, neurodegenerative movement disorders. All right, so for the neurodegenerative movement disorders, this is the highest yield thing in neurology. I know I already talked about that when it comes to intracranial hemorrhaging, but that as well as neurodegenerative movement disorders are very, very high yield when it comes to neurology. There are going to be a couple other pages on here that are also very high yield, but this is probably the highest of yield things, okay? So let's start off one with Parkinson's disease. Okay, key takeaway for Parkinson's disease is that it's a loss of dopaminergic neurons in the substantia nigra pars compacta. Okay, that's the first end-all be-all that you need to take away. Okay, now a key thing to understand about Parkinson's disease is that in Parkinson's, the majority of the substantia nigra dopaminergic neurons are lost prior to any onset of motor symptoms that occur. Okay, and the reason behind that is because during this period, dopamine depletion is offset by upregulation of postsynaptic dopamine receptors. So, although we've lost majority of the substantia nigra dopaminergic neurons that produce the dopamine before symptoms onset, the reason symptoms don't become essentially shown is because in the postsynaptic cleft, on the postsynaptic membrane, we start to upregulate our dopamine receptors due to the fact that we have a decrease in dopamine. So that kind of holds back symptoms for quite a bit until we actually have a full decrease in dopamine that cannot even be compensated by an increase in dopamine receptors. Okay, so that's a very key takeaway for Parkinson's. But remember, Parkinson's disease is the loss of dopaminergic neurons in the substantia nigra pars compacta. Okay, now you're usually going to see symptoms onset after the age of 60. And the reason I'm being so key about that is because if you see some types of symptoms that are similar to Parkinson's that are occurring before 60, then don't think Parkinson's, okay? For majority of the time, Parkinson's is going to present after the age of 60, okay? And the presentation is going to look like, one, they're going to have the resting tremor, the pill rolling tremor at rest, right? They'll have rigidity. They call it cogwheel rigidity or lead pipe rigidity, meaning that they have really an inability to move, right? They're very rigid. They have akinesia or bradykinesia, which is just like a shuffling gait, small handwriting. Okay, they have, once again, struggle moving. And lastly, they'll have a postural instability. So they're increased risk of falling, okay? Now, what you want to know is that histologically, the affected neurons will contain Lewy bodies, okay? It's very, very important. Lewy bodies are going to be seen in Parkinson's, okay? And they're intracellular eosinophilic inclusions composed of alpha-synuclein. And what they love to talk about is Parkinson-nuclein. So that's how you remember that alpha-synuclein is seen in Parkinson's disease. Okay, alpha-synuclein is very, very, very important to the process of Parkinson's disease. They want you to know that. They want you to be able to pick that word out for Parkinson's disease, okay? And they want you to see a photo of it. There's going to be like somewhat of like brown inclusions, brown eosinophilic inclusion bodies. That's going to be alpha-synuclein, okay? So take a look at it, look it up. And what they also want you to know on photo is that when you're looking at the substantia nigra, you will see a loss of pigmentation. Okay, so take a normal look at the substantia nigra and you can see that it's dark. But when you look at a Parkinson's patient, you'll notice that the substantia nigra is much, much lighter. I guarantee you're going to see one photo on your exam of that, okay? Because they love that, a gross anatomy photo of essentially the pons, okay? And they're going to show you that, okay? Or of the substantia nigra, okay? Now, a very important thing is that Parkinson's disease can be treated by suppressing the subthalamic nucleus. So we know that the subthalamic nucleus is essentially going to inhibit movement for us, okay? So if we inhibit or suppress the subthalamic nucleus, then we will have an easier time moving, okay? That's rarely done, but I want you to just think about that process and why it makes sense. If we inhibit the subthalamic nucleus for a patient with Parkinson's, then we can kind of alleviate some of those akinesia symptoms that they experience, okay? Now, one of the last things that they like to talk about is that dementia usually is a late finding in Parkinson's. Okay, so you're going to have dementia, but it's going to be much, much later in Parkinson's disease. But if you were to have like a TBI, it can accelerate neurodegeneration and age of onset of Parkinson's. So any type of traumatic brain injury can lead to an increase in acceleration of neurodegeneration and the age of onset of Parkinson's disease. So although I told you after the age of 60 is kind of like a hard rule, remember, not everything in medicine can be a hard rule. So whenever you have a traumatic brain injury, it can increase or essentially decrease the age of onset and accelerate the neurodegeneration seen in Parkinson's disease. All right. So overall, let me run through it one more time. Parkinson's, because this is very important. It's a loss of dopaminergic neurons in the substantia nigra pars compacta. Okay. And you can see depigmentation, okay, on the actual brain. Okay. So take a look at the piece of tissue that they're talking about. You'll see depigmentation occurring for patients with Parkinson's disease. The patient is going to present with pill rolling tremors and cogwheel rigidity or lead pipe rigidity. They have akinesia and postural instability. Okay, postural instability. Sorry. Now, they are treated some with subthalamic nuclei suppressions, but that's not going to be majority of patients. And lastly, majority of patients will not have symptoms until way, way, way later in the course of the disease, because what happens is that due to the lack of dopamine, we have an upregulation of the postsynaptic dopaminergic receptors. Okay? And then on histology, you see Lewy bodies that contain alpha-synuclein. Very key to all of this. All right, so that's our Parkinson's disease. Next, we're going to go to Huntington's disease. Huntington's disease, the end-all be-all, once again, is the loss of GABAergic neurons in the striatum. Remember that GABA is our main inhibitory neurotransmitter in the body. So when we have loss of GABAergic neurons in the striatum, we essentially lose that inhibitory response. Okay? So loss of GABA is the main cause of Huntington's. All right? You can also see loss of acetylcholine. Okay? Caudate atrophy will be seen with a decrease in acetylcholine and GABA. But once again, loss of GABA is the main cause of the symptoms. Okay? Caudate atrophy with decrease in acetylcholine is secondary. All right. Now, what are you going to see? It's usually due to the fact that we have a trinucleotide repeat of CAG. Okay. And when those repeats become much, much larger, it's going to be causing symptoms of Huntington's disease. All right. It's going to be found on chromosome 4. All right. And patients start to have kind of typical manifestations occur from 30 to 50 years of age. And you get chorea, which is just the abnormal movements, right? Athetosis, abnormal movements, snake-like movements of the fingers. Aggression, they become personality changes. They get depressed, and they also have new onset dementia, okay? So a lot of patients that have Huntington's disease sometimes initially get mistaken for some type of substance use because of all these changes in their personality, all right? It's going to be a very weird presentation, but remember, keep in mind the age of onset of 30 to 50 years old, all right? Now, you're going to see, once again, atrophy of the caudate and putamen, all right, with ex vaccio ventriculomegaly. You're going to see decrease in GABA, the key thing, as well as decrease in acetylcholine, all right? But GABA decrease is the key factor here, all right? And what you need to know about Huntington's disease that they like to ask about is that you have a gain of function that promotes histone deacetylation, okay? And when we have histone deacetylation, it leads to an increase in DNA histone binding. Okay. And so then when you have DNA histone binding, it leads to a loss of expression of certain things. Okay. And that's what Huntington's disease does. So it's a gain of function mutation that promotes histone deacetylation. All right. I want you to understand that. That's something that they can ask about. Okay. And so once again, you're going to get enlargement of the lateral ventricles, all right, due to ex vaccio ventriculomegaly. All right. So overall, what do I want you to know from Huntington's disease? It's a loss of GABAergic neurons in the striatum. You're going to see atrophy of the caudate and putamen with ex vaccio ventriculomegaly. You're going to see a total loss in GABA and a decrease in acetylcholine. You're also going to see gain of function mutation that promotes histone deacetylation. The patient's going to present at around 30 to 50 years old, depending on how many repeats they have. The more repeats, the earlier age of onset. And the patient's going to present with chorea, athetosis, aggression, depression, and dementia. Okay? Never, ever miss a Huntington's disease. If you're able to pick out all those symptoms, you're able to get the answer. Okay? Now, I said, as you increase the amount of trinucleotide repeats, you get early age of onset and worsening symptoms. Okay? And that is known as anticipation. Okay? Anticipation is just the expansion of the trinucleotide repeat CAG that leads to earlier onset of symptoms as well as worse symptoms compared to the generation prior. Okay, they want you to know anticipation. All right? That's Parkinson's and Huntington's disease. Now for our dementias. Dementias are very, very key to the neuro exam. It's very, very important to understanding dementia. So all that dementia is, once again, is that it's a decline in cognitive ability, okay? But they have intact consciousness. So let's start with neurodegenerative, okay? So there's 3 specific types of neurodegenerative dementias that we care about. The first one you've probably heard of, Alzheimer's disease. It's a horrible, horrible disease, okay? Now, this is most common cause of dementia in older adults. So these patients are going to be presenting to you in old age, okay? Because advanced age is the number 1 strongest risk factor you have to know, okay? So if you ever see a patient that has loss of memory and they're an old person, start thinking Alzheimer's as your first differential, okay? Another thing that it's associated with, not only advanced age, but also Down syndrome. Patients with Down syndrome have an extra chromosome 21, okay? Because of the extra chromosome 21, it leads to an increased risk of Alzheimer's disease because chromosome 21 creates amyloid precursor protein. So the more amyloid precursor protein we have, the increased risk of Alzheimer's. And we'll talk about why, okay? Now, it's going to be associated with altered proteins. So there's 2 types of proteins that they want you to know. There's ApoE2 protein. If you have the ApoE2 protein, it decreases your risk. It's protuctive. That's how they remind you of ApoE2 is protuctive or protective, okay? ApoE4 increases your risk of Alzheimer's, and that they just say ApoE4 is for Alzheimer's disease, okay? Very, very key to understanding it. I remember getting a question on it, but it's easy, okay? Now, another thing that you should take away from this is that you'll have widespread cortical atrophy, okay? And it mainly affects the hippocampus, which makes sense because the hippocampus is our memory site. So we're going to have widespread cortical atrophy at the hippocampus, which essentially leads to Alzheimer's disease, okay? Very, very key. So when you look at a patient's brain that has Alzheimer's, they have mass amounts of narrowing of the gyri and widening of the sulci because they have just atrophy of the cortex, okay? Specifically at the hippocampus. You're also going to see decreased levels of acetylcholine in the brain, okay? So decreased levels of acetylcholine in the nucleus bacillus caused by a total decrease in acetyltransferase, okay? So at the nucleus bacillus, you're going to have a decrease in the amount of acetylcholine. And that's going to be due to the fact that you have an overall decrease in acetylcholine transferase, okay? Now, what do you see on histology? 1, you're going to see neurofibrillary tangles, okay? Neurofibrillary tangles. And this is going to be intracellular hyperphosphorylated Tau, okay? That sounds like a bunch of random words, but I promise you it comes up on the exam. In Alzheimer's, neurofibrillary tangles are formed when the Tau is hyperphosphorylated, okay? And it dissociates from its associated microtubules. So they want you to know that process. That's what occurs, and that's why it becomes insoluble, and so it can't be cleared out, and that's what can lead to the dementia seen in Alzheimer's disease. So what happens, once again, in Alzheimer's, the neurofibrillary tangles are formed when Tau, okay, hyperphosphorylated Tau protein. So when Tau is hyperphosphorylated and dissociates from its associated microtubules. So it essentially is dislodged and becomes insoluble. All right, very key. Next, you have senile plaques, okay? And this is extracellular beta amyloid core, okay? So we have a buildup of beta amyloid in the brain of Alzheimer's patients. That's the number 2 key thing histologically that you will see, okay? Number 3 key thing is going to be Hironi bodies, all right? Hirano bodies are just intracellular eosinophilic, like rods in the hippocampus. That is the lowest yield thing, but I just brought it up for just kind of bringing all of the Alzheimer's photo together. But what you need to know are the neurofibrillary tangles that are hyperphosphorylated Tau and the senile plaques that are beta amyloid, okay, build up, all right? Now, in Alzheimer's disease, we can try to treat them with acetylcholine esterase inhibitors, okay? But it improves their cognitive function, but it has no change in the disease course, right? Because if you ever have something that changes the disease course of Alzheimer's, you'd be a very rich person, okay? That has not happened yet. But acetylcholine esterase inhibitors help improve the cognitive function of these patients, but they do not change disease course. Because once again, if you give them acetylcholine esterase inhibitors, it will overall increase the amount of acetylcholine in the brain, which is one of the main issues of Alzheimer's, okay? But we found that it does not change the disease course, all right? So that's all for Alzheimer's. I know it's a lot, but it's very important to understanding. Also, take a look at what neurofibrillary tangles look like and what senile plaques look like, because they can sometimes throw it on the exams. Next, for neurodegenerative dementias is frontotemporal dementia. This is called PIC disease. All right, PIC disease. Now, what I want you to know for frontotemporal dementia, also known as PIC disease, are about like 4 key things. First, the patient's going to present with disinhibition. So they're going to be socially inappropriate. Okay, socially inappropriate behavior. If you see a patient that's not older age, okay, just like it could be like any type of age, not like young, but like in their 50s or later, and they have socially inappropriate language randomly, or they start to act weird, that's just like you would never expect them to do that. That's a first hint of frontotemporal dementia, or FTD, okay, or PIC's disease. Number 2, you get loss of empathy. Okay, so once again, the patient's acting weird. Okay, their personality is completely changing. They have loss of empathy and they're having a weird, socially inappropriate behavior. Number 3, you have hyperorality. Okay, although this gives it away a lot of the time, they don't give it in a lot of the questions. They'll put it only in some questions. If you see a patient that's binge eating, specifically like sweets, that's your answer to frontotemporal dementia. Okay, but they sometimes don't give it to you because they're kind of annoying. But if you see like someone that has hyperorality, they're binge eating a lot of sweets, along with this social inappropriate behavior and loss of empathy, that's going to be key. And number 4, compulsive behavior. They start doing things out of compulsively, randomly, that they just never used to do prior. Okay? Now, you're going to see inclusions of hyperphosphorylated tau, okay, just like Alzheimer's, right? And you're going to see ubiquitinated TDP-43, okay? Very, very important. So hyperphosphorylated tau is our PIC bodies, which we already talked about in Alzheimer's, but you also have ubiquitinated TDP-43, okay? And what you're going to see grossly is frontal or temporal lobe atrophy. Now the question is, how can I differentiate this from Alzheimer's disease? So FTD versus Alzheimer's disease, okay? Well, frontal temporal dementia involves the anterior temporal and prefrontal cortexes, right? Alzheimer's disease has widespread cortical atrophy, okay? But the main differentiation from Alzheimer's is that FTD, or frontal temporal dementia, has early onset personality changes. Remember, Alzheimer's number 1 risk factor is like way later on in life, advanced age. FTD is a little different. It has early onset personality changes. So they can tell you that this patient is presenting in like their 40s with these weird personality changes. It's not going to be Alzheimer's, it's going to be FTD. So that's a key takeaway that I want you to understand for differentiating frontotemporal dementia from our Alzheimer's disease. All right? Now, next and lastly for our neurodegenerative dementias are Lewy body dementias. All right? Now, Lewy body dementias, key takeaway is visual hallucinations. Okay? Visual hallucinations is key. All right? Now, they can also have REM sleep behavior disorders. So whenever someone tells you that this patient has like dream enactment in REM, so they're moving their arms and like they're kicking during REM, as if they're fighting, like fighting someone in their dream. They're actually doing it in the real life. That's called dream enactment in REM. That tells me that there's some type of development of alpha-synuclein neurodegeneration, which is seen in Lewy body dementia. Okay? And then you have excessive sustained muscle tone during REM sleep can also be a sign of Lewy body dementia. Okay? So any REM sleep behavior disorder is going to be common in Lewy body dementia. Now, you might be asking me, wait, whoa, you said alpha-synuclein just now for Lewy body dementia. I thought that was Parkinson's. Well, Parkinson's and Lewy body dementia somewhat go hand in hand. They're very similar, okay? So you will also see alpha-synuclein potentially in Lewy body dementia, but they're not going to be like annoying like that. If you see alpha-synuclein, go with Parkinson's disease because that's usually what they have. And honestly, Lewy body dementia, if there's cognitive and motor symptoms that the onset is less than 1 year apart, that is what Lewy body dementia is. But if not, they consider it just dementia secondary to Parkinson's disease. So that's how close they are in reality. But once again, if you see any REM sleep abnormalities with visual hallucinations, think Lewy body dementia. That's like the only takeaway I should give to you, okay? So whenever you see like REM sleep behavior disorders, like if they're doing dream enactment or if they have sustained excessive muscle tone during REM sleep, think Lewy body dementia. That's my key takeaway, all right? Next is for vascular dementia. All right, so we're done with neurodegenerative dementia. We now are on to vascular dementia. Now, for vascular dementia, I want you to take away just like the key point that it's just secondary to older adults getting a bunch of different arterial infarcts in the brain. So you have so many arterial infarcts in the brain and chronic ischemia, it leads to dementia later on in life, okay? So they're going to present with a stepwise decline in cognitive ability, okay? And so these are the two takeaways that I always think about for vascular dementia. One is that you get executive dysfunction. So they have difficulty organizing things, difficulty like just doing normal organization stuff that they used to be able to do, executive function, okay? Number two, you have localizing neuro findings. So you can get asymmetric reflexes. You can have muscle weakness with gait abnormalities, okay? And the reason behind that being asymmetric, all of this is gonna be asymmetric reflexes with asymmetric muscle weaknesses and gait abnormalities, is because with vascular dementia, you have a bunch of different parts of your brain, okay, in no clear order, having multiple infarcts. So each of those different infarcts are gonna affect different parts of your body. So that's why you'll see asymmetric kind of bodily symptoms. So asymmetric reflexes and asymmetric muscle weaknesses. That's a key takeaway for vascular dementia. All right. Now, once again, on like grossly, you're going to see multiple cortical or subcortical infarcts, as well as like hyperintensities. That's just telling you that there's multiple areas of infarctions and ischemia. And then you can also see arteriosclerotic changes affecting small cerebral vessels, right? Because that can also be a result of infarcts in the brain. All right. That's vascular dementia. The last causes of dementia are going to be infective dementia. The first one is, I'm going to butcher this name, but it's like Creutzfeldt-Jakob disease, okay? And this is a prion disease. And so it's just accumulation of protease-resistant protein. So it's an infectious protein, which is crazy to think about. It's super rare, but that's what a prion is. It's an infectious protein that cannot be broken down by proteases, okay? What they want you to know specifically is that it's rapidly progressive, okay? Rapidly progressive. This is horrible. And it's typically sporadic, okay? It's sporadic. It's random, okay? They don't know what the cause is, but it just randomly appears, okay? And what you want to know is histologically, it looks like spongiform cortex. So take a look at the spongiform cortex in your book or take a look up of it online. You're going to get tons of questions on that, okay? And it's very easy to identify. It literally looks like a sponge, okay? So it forms spongiform cortex from Creutzfeldt-Jakob disease, okay? Now, it's associated with the periodic sharp waves on EEG 1433, okay? 1433. And that's pretty much all you need to know about Creutzfeldt-Jakob disease. The last one that causes dementia is HIV, HIV-associated dementia. For HIV-associated dementia, what I want you to take away from this is that you have microglia nodules with multinucleated giant cells. I know I already discussed this previously, but I want to make it a point. What happens is that HIV infects the microglia, all right? And it forms multinucleated giant cells. And that's how you know HIV is causing the dementia, okay? In the CNS, HIV is going to infect and replicate in the macrophages or the microglia, right? The microglia are the macrophages of the CNS. It's going to form multinucleated giant cells, okay? I can't be more clear about this, okay? You're going to have cognitive deficits, gait disturbances, irritability, depressed mood. What I want you to take away from all of this, from all dementias, is that depression is a very common associated symptom with dementia. Okay, so a lot of the times they might potentially want you to like check for depression prior, okay? But just keep that in the back of your mind. A lot of these patients that could potentially present as depression, they could try to be masking dementia in the question stem, okay? But that's all. That's the type of neurodegenerative movement disorders that you need to understand, and dementias, neurodegenerative dementia, vascular dementia, and infective dementia. If you have any questions, please let me know. This is probably the hardest page, but it is the highest yield page. You have to understand the histology specifically and why all of these processes occur.